Let's see what he has to show us today. Dr. Sri Ganesh.
Good afternoon, respected jury, Supreme Judge. This is a case I would like to...
And public prosecutor, sir.
And my defense counsel.
Sir, he has to take off his shirt, no sir, to show the muscles. Salman Khan. He is the Salman Khan of ophthalmology.
This was a 20-year-old male who had undergone ICL surgery about a year ago. And this was the power of the lens, plus 23 for almost 12 diopters of hyperopia. Developed cataract after a year. And this was the situation. We had various options. One is the calculated power of the lens was 47 diopters. One was either to get a customized lens, remove the ICL, put the lens. The other was to actually remove this ICL, put a standard lens and put back the ICL. Then I thought, can we do the cataract surgery without removing this ICL? And we came up with this solution where I went ahead and did the cataract surgery while still maintaining the ICL. You can see that the rexus is being performed under the ICL. It's a high hyperopia, almost about 12 diopters of hyperopia, but he had a good ACD. That's why I put in a ICL and he was very happy. He recorded about 6/12 vision after the ICL surgery. But then he developed a cataract, anterior subcapsular cataract. So this is the technique which I'm doing here. I complete the rexus, and after that this is a very soft cataract. The completion of the rexus under the ICL. Did a hydrodissection, it's a soft cataract. Went in with IA. You don't really need to use phaco here. It's being done under topical anesthesia. You can see what I did was I just lifted the proximal haptics of the ICL into the antechamber. The distal haptics were still in the sulcus. So went in and then aspirated the soft cataract and the cortex, and then decided to put a standard IUL because the ICL was already correcting the hyperopia, so we didn't have any means of calculating the exact power. So I put in a 22 diopter IUL as a standard IUL. And anyways, even the biometry in these very high hyperopes with short axial lengths is not very accurate, and you can get errors in biometry. So this is what we planned. Instead of doing a piggyback lens, putting two lenses, I decided to retain the ICL, and then you can see that I have cleared the cortex. That's the subincisional cortex being cleared. The bag is clear now, and that's the last bit of cortex. Then put in viscoelastic, inflated the capsular bag. That's the IUL being inserted. It's a standard 22 diopter lens. So I'm inserting the lens into the capsular bag under the ICL. The viscoelastic between the ICL and the cornea acts like a cushion and even prevents the fluid from hitting the endothelium. It's like a hood, and it maintains the integrity of the endothelium there. That's the lens being inserted, and after that I just have to go in and tuck the proximal haptics back into the sulcus. So we have two lenses there, the ICL and the IUL, and this patient actually had a good postoperative outcome. He had a residual power of about 1.5 diopters and 6/12 vision with the correction. He actually didn't need the glasses also, and he was very happy that he could maintain this ICL because he was very happy after the ICL surgery. His life had changed and he didn't want to actually have the ICL removed. And so we were able to kind of maintain the ICL, manage the cataract, and the patient had paid so much for the ICL, so he was happy that he still had the ICL, and it's now about 4 years. Patient is doing very well. Thank you. I rest my case.
Your Honor, may we have the lights on, please? Lights on, please. Yes. So, may I begin my trial, Your Honor?
Continue, please. The waistcoat also comes off? So the waistcoat also comes off, sir?
Yes.
There you are.
Yes. I'm just following the instructions of the Supreme Judge.
Yes.
So all of you want to see the
I hope-
waistcoat off or not?
Is he trying to threaten me?
Muscles.
I'm not-
yes.
I call upon the dignity of this court to be sustained.
He is not
For the
threatening
knowledge
you.
of the
I am only
public-
trying to
public
intimidate you.
prosecutor.
I'm not threatening you, my
Sir, he
dear
is
public
not
prosecutor.
threatening you, prosecutor.
Exciting him.
The public prosecutor is
exciting him,
threatened. The public prosecutor is threatened. Being a ICL surgeon, one of the beginning of the phakic IOLs, he has seen something a new way of
Objection, my
approaching.
lord.
Sir, by the way,
public
are you
prosecutor
both
cannot-
working together, both of you?
He has seen a new approach, so he is getting nervous.
Sir, may I have a chance to speak?
Sir, let him show the biceps, no?
I'll show mine. Unnecessary, irresponsible manipulations. Why? Why do these all things? What is the necessity? What about the biometry? How can you get an accurate biometry in this patient? The shift of the ICL, the position of the ICL, can anyone ever determine this? He is guilty. Don't let him go.
Dr. Sri Ganesh, what was the preoperative refraction?
It was 12 diopters, plus 12.
He was hyperopic.
He was highly hyperopic, young patient, highly hyperopic, had good accommodation, so I didn't want to do a refractive lensectomy in the first position. And he had a good ACD, so I went in for a hyperopic ICL, and the patient did very well. He was very happy with the surgery, had uncorrected 612 vision. And then year and a half later, he developed this anterior subcapsular cataract. And then we were wondering what to do. And then this is something which is, we did innovative, and then the patient also is very happy that he still could maintain his ICL because he had paid so much.
I think with all these so much of ICLs now being accepted as a answer to high myopes and high hypermetropia, I think he has come up with a very innovative way, keeping the ICL there. And my public prosecutor is talking about the biometry. I think we are still evolving, and as he has said, he has put a standard IOL power. Maybe this is a learning phase where you could come up with a
Answer my
newer method.
question on the biometry,
Yes,
please.
Biometry, even if, but the biometry gave 47 diopters, but even with a good formula like the Haigis for short eyes, you cannot hit the nail on the head.
Yes, absolutely. You are
And
never.
this we were able to see because the position of the ICL does not change. It remains in the sulcus, it's the same position. It is better to put an ICL as a secondary piggyback lens because there's a definite space and the risk of intralenticular opacification is almost zero. If you put in two lenses, suppose I had done biometry, 47 diopters, I had to have put in two IOLs, then the incidence of red rock syndrome,
Hypermetropic eye,
manipulating,
this was a
putting,
high hypermetropic
putting one lens in the bag, another lens in
Do
the
you
sulcus.
remember Mahipal? What about your opinion, sir? You are not talking at all. You are
What
missing?
our defendant
Sir,
already
did you take
said is
permission
the
from the
right
court for missing?
way to do. One IOL, wait for stability, put a second IOL in the sulcus. A
Just wait, let
piggyback
us hear the
IOL.
jury member, Center for Sight.
Center for Sight, sir.
Basically, you are trying to do a piggyback with an ICL,
Yes.
right?
Yes.
So, if you had put an intraocular lens and then waited for the calculation, what are the basis of the calculation that you had for this?
Basis of the calculation, if you want to put a secondary IOL, then you can do it as a primary position, a piggyback, if you want to put an IOL. If you want to put an ICL, then you remove the cataract, put an IOL, do the post-operative refraction, and then select an ICL, and then you
Yeah,
can
so-
put it. But even then, it would have been a little better, but
So, how are you aware of the post-operative behavior of an ICL working as a piggyback lens? There are reports of various other materials that are used which give you good result in in a piggyback. So, why not go with the conventional thing? Put one lens, take out the ICL, put one lens, and not make a heroic surgery in the entire thing. Just do a normal.
Acrobatics, sir.
it's not very difficult. In fact, acrobatics is very easy. I do it every
Yeah, but
day.
you have a lens which is.
But the thing is, what happens is, if you remove the ICL, okay, and then remove the cataract, put an IOL, and then wait For some time there's capsular contraction, again there is high residual hyperopia, and the patient is very uncomfortable, has to wear thick glasses. And then if you put a primary, you put two lenses, again then the refraction may not be very accurate because you have to calculate it, and there is some amount of error which can come even by putting two lenses, positioning the lenses.
Let us ask Dr. Rajsekar. Do you remember?
1 second, I think he has a femto laser. It would have been better to be less acrobatic and less heroic if you could.
Sir, did you use femto, sir?
You could have used a femto to do
No,
the
sir,
capsulotomy without going
this was
underneath.
before the era of femto. This was before the era of femto.
Okay.
So,
What about you, Dr.
Yeah, can you have an opinion of the House, sir?
It's a heroic surgery done very well, which Sri Ganesh can do. But do you think plus 1.5 and again addition of 4.5 is justifying the patient's thing, like Dr. Mahipal was saying, you could have removed, and even if it were to be another setting, you would have given better.
but you are not sure of the refractive outcome. You can always do a surface ablation or LASIK for 1.5.
But this is more unsure. This is more unsure because ICL is
Yes,
again going to
the
go.
main challenge is the biometry here, but even for a very high hyperopia, short axial length, you still have challenges there, and if you're putting a piggyback lens, then again even that has its own risk of complications. Intralenticular
Yes,
opacification, interlenticular opacification is a big problem, then is very difficult to treat. But if you have an ICL, you don't have that risk.
So
and
how-
here I was not able, I was still able to maintain the ICL, not
Sri,
remove it.
let's get
Say,
some more.
maintaining
Yes, tell
ICL.
us.
Dr. Sri Ganesh, the IOL implanted was a monofocal IOL,
It was a monofocal lens.
so that patient lands up with presbyopia now. Instead, a monofocal implant with the highest possible plus diopter could have been implanted, and 6 weeks down the line, a sulcoflex, which is a multifocal sulcoflex, could have been implanted. So he would have got rid of all the problems.
He still can do it.
Sir, put one more lens inside. Put one more and then we'll show it in the OPL.
I think we'll have the last word from Dr. Ramamurthy.
No, 1 minute.
Putting in a lot of
ICL. This circumflex is an alternative.
Dr. David Chang.
So I think the prosecutor has raised a lot of good points about why this might not be something we'd recommend for everyone to do. But for this particular patient, the point is that no matter what formula we use, when you do piggybacks, we're very poor at hitting emetropia. A lot of the patients get unwanted dysphotopsias. And so I think that given his ability to do this, for this particular patient, he really didn't do any harm. And why not give it a shot? Because if there was a problem, he was off by 4 diopters, it'd be relatively easy to pull that lens out of the sulcus and put another one in its place. If for some reason there was some optical problem, buckling of the lens, it'd be still relatively easy to pull it out and put in a secondary. So I again would question whether this is an approach I would recommend in general for these patients, but for this specific patient, I think he did a good job and it was reasonable.
And Ram, you were saying something?
I think I sort of reiterate what Dr. Chang said in the sense that maybe because of Sri Ganesh's muscles, when he puts something somewhere, it stays there. But as far as lesser mortals, lesser surgeons are concerned, we must remember that the ICL is supposed to go in that almost non-existent sulcus space. You are removing a 5 millimeter normal cataractous lens or a regular lens and putting in an intraocular lens which is just of 1 millimeter anterior posterior diameter. I hear that there is a tendency for ICLs being used as a piggyback lens by other surgeons also. Maybe it's not a good idea. Maybe in this case, because of a lack of choice, he did that. But otherwise, using a regular piggyback lens may be a better idea because the kind of spacing, the kind of configuration that the eye has, when the cataractless lens, the lens is replaced by an intraocular lens is very different. And ICL has not been substantiated to be placed as a piggyback lens.
Gee.
The sulcus doesn't change.
I think he's done a great job, and because he's Superman, he can do all these acrobatics very well.
Oh, we never get praise like this from G.
Thank you.
Boris?
I do think he's not guilty. I believe the case was done perfectly, and I think I will agree with David that probably we have many options in this case. And this was not the bad one. probably, I don't know whether I will go the same way, but I think it's justified. Yeah.
So let's ask the jury, guilty or not guilty?
All lights
Not
on.
guilty, not guilty.
Not guilty.
अरे ये भी बच गया.
He has threatened every one of us.
क्या है?
How much dumbbells you lift?
नहीं मैं तो बचाया आपका. Yes.
Wait. Or how many?
Sir, he's asking non-vegetarian now.
Sound.
Congratulations. So, before we end, one thing which I want to tell everyone here is, this whole concept of the court-martial is the person on the right path of Biswasis. He had come to us first. Really, let's hear it for him. Because I remember Pata came to me for the IIRSI and he came out with this concept of the court-martial. It's phenomenal.
Thank you very much. But I have a creative team behind me and that's them. So the creative team has really helped. But what has really helped is the appreciation from every one of you. And this actually is a session full of science. The science is the most important part. We just make a fun and frolic affair out of it, just to give it a backdrop. But the science is the essence. Thank you very much for being with us. Thank you.